When I posted my short case discussion on tetralogy, there was a request that I must do small discussion on cyanotic spell. So here it is. So cyanotic spell is otherwise called paroxysmal hyperpnea. So what is cyanotic spell? There is a increased rate and depth of respiration, most often because of a sudden exertion or excitement. Then that will cause increasing cyanosis, and increasing cyanosis means less blood is going into the pulmonary, which means that the murmur may become fainter. And then the child may become limp, unconscious, through a convulsion, may suffer a CVA, and death can occur or recovery at any of these above stages. Although I said death can occur, there are other causes of death in top. For example, a CVA or infective endocarditis. Now, what is the effect of hyperventilation? Normally, what will happen when you are hyperventilating? Your carbon dioxide gets washed out, your oxygenation improves, your partial pressure, your saturation of hemoglobin with oxygen, everything increases. And when you hyperventilate, the pH also goes up, not down. But in TOF, what happens is a fall in oxygen saturation. Why? When you are ventilating, it is an exertion. So there is an increased venous return to the right atrium. It comes to the right ventricle. And when it is pumping, there is obstruction here. So it directly pumps into the aorta along with the pumping from the left ventricle. So left ventricle and right ventricle almost directly pumps into the aorta. So much so, more and more of desaturated blood reaches your circulation. Because of hyperventilation, there is increased venous return to this atrium, increased right to left shunt, because instead of going this way, it is going this way, because there is obstruction here. And so, because the blue or the desaturated blood is going into the aorta, there is more and more of desaturation of systemic circulation. The age is around 2 months to about 2 years. Time of the day is usually in the morning hours. It lasts for about 10 to maybe up to 10 minutes to up to about 1 hour. Precipitating factors are awakening from sleep in the morning, crying, defecation, that is some sort of exertion, feeding, unpleasant stimuli like needle prick, crying, etc. The important thing is the spell need not correlate with the severity of the TOF. Actually, it correlates more with the way the infundibulum goes into spasm. Now, cyanotic spell, why is it in the morning? During sleep, there is reduced oxygen demand. The oxygen saturation is more or less good. So the respiratory center is now used to not a reasonable oxygen saturation. On waking up, there is some activity like defecation, crying, etc. So because it is an increased activity, there is need for more oxygen. As I described in the previous slide, the increased venous return actually without oxygenation goes right into the aorta. So the systemic carbon dioxide partial pressure increases and oxygen saturation decreases and pH also decreases. And the frequency of spell decreases after morning hours because after some time your respiratory center gets used to lower saturation. So it may not trigger another hyperventilation at a lower saturation, which has actually triggered a hyperventilation in the morning hours. It is infrequent in high altitude natives because already their respiratory center is used to a very diminished saturation. So the respiratory center response to hypoxia is less aggressive. Now, cyanotic spell, what happens? In pulmonary resistance is very high. This is very high, and there is an infundibulum down there. So that goes into spasm. So right ventricular outflow tract obstruction is more, and it is unyielding. So much so, if there is a contraction of both ventricles, this ventricle, right ventricles, find it easier to pump it through the ventricular septal defect into the aorta rather than into the pulmonary. And systemic vascular resistance is dynamic. Suppose you are exerting, the muscles need more blood, more oxygen, so there will be vasodilatation. So systemic vascular resistance will come down. Suppose systemic vascular resistance is low, that means more and more blood will go into the aorta from the right. In exertion, what happens? There is hyperpnea, increased venous return to right ventricle, but this will not yield. So this increased venous return actually goes into the aorta only. So there is more right to left shunt. And once there is more right to left shunt, increased carbon dioxide and decreased oxygen saturation or partial pressure. So what happens? The system wants more oxygen, oxygenated blood, so it dilates its vessels. So systemic vascular resistance decreases. Once the systemic vascular resistance decreases, it is far more easier now to pump blood right into the aorta. So actually the right to left shunt now increases. So this is the pathology of what happens in excess. And the RVOT spasm, that is infundibular spasm, is supposed to be the key element. Cyanotic spell can still occur in pulmonary atresia also, where there is no infundibular spasm as such. Although we say infundibular spasm as the primary reason, it may not be the only reason. And when there is tachycardia, there is increased RVOT contractility. That means right ventricle is contracting and the infundibulum is contracting. So less blood is going into the pulmonary circulation. So increased cardiac output actually causes right ventricle directly emptying into the aorta. What can we do for treatment? You can either decrease hyperpnea, decrease the venous return, avoid desaturation, and decrease pH. So that's what we can do to reduce the right to left. So how can we do that? Knee chest position, oxygen inhalation, morphine, propranolol. These four are the cardinal things. I teach my undergraduates with this acronym POM, that is position, oxygenation, morphine, and propranolol. And M stands for one more thing, metabolic acidosis correction. The other things are like alpha stimulants, like phenylephrine, noradrenaline, etc. Phenylephrine, yes, it is a alpha stimulant. So alpha actually contracts the blood vessels, so the systemic vascular resistance increases. Noradrenaline is both alpha and beta stimulant, but beta is far less as compared to very predominant alpha. And in addition, we are anyway giving propranolol and blocking the beta. And even if noradrenaline has got some beta stimulant effect, that is already blocked. So you can give noradrenaline also. And for metabolic acidosis, you can give sodium bicarbonate. If it is not settling, the other options are general anesthesia and a planned emergency shunt in case the recurrent life-threatening spells are occurring. Knee chest position, how does it act? It increases the intra-abdominal pressure. So increased venous return from the splanchnic area. Splanchnic venous saturation is better than that of lower limb. So it's not a very bad idea to have some increased return from splanchnic area. And when you are squatting or knee chest, there is kinking of femoral veins. So reduced venous return from lower limb. Lower limb has got very low oxygen saturation. Very unsaturated blood is prevented from reaching the right area. When the right atrial load is less is going to the right ventricle, and so there is less of right to left. How does morphine act? Morphine is an analgesic and a sedative. It sort of sedates you. So this hyperpnea or the respiratory rate comes down. Bradypnea is the side effect of morphine. So the respiratory rate comes down. Increased venous return is not happening because exertion part is less now. And the RVOT resistance, because this is a relaxant, I mean, the rate has come down. There is more time for the ventricles to remain in diastole. And so the right ventricular outflow tractor, that is the infundibulum, also gets more time to be relaxed than contracted. So there is less of right to left shunt. Actually, it was during a spell, the right to left shunt was increased. Now it settles. And because less of right to left shunt, the desaturation of systemic blood also will be less. So much so, the systemic vascular resistance will not come down substantially. That is how morphine works. And propranolol, it reduces heart rate and the contractility of the heart, which means that right ventricular outflow tract contractility also is reduced. So much so that the block to the pulmonary circulation is slightly less now. And because of the reduced heart rate, time the heart is relaxed or the infundibulum is relaxed is also more. Systemic vascular resistance increases. How? Alpha and beta receptors are there. Alpha is vasoconstrictive, beta is vasodilation and cardiac stimulation. When we block beta, then alpha has got unrestricted action without modulation from beta. Systemic vasculature goes into contraction. And so just imagine the systemic vascular vasculature is contracted. That means just imagine that there is you put a block here. So much so, your right ventricle is now trying to push blood this way, but there is a block, systemic vascular. So more blood now tend to go to the pulmonary circulation. So that is how it helps. Propranolol is more useful in patients with milder forms of cyanosis, and also in patients who show marked reduction in saturation with activity and hyperventilation. That is, patients with the propensity for pronounced infundibular spasm. In such patients, propranolol works very well. And what is the prophylaxis? We must prevent anemia by giving iron and oral propranolol on a long-term basis. For an acute event, we have given propranolol IV. Here, we can give oral on a long-term basis. Thank you for watching.